I'm Rod Rourke, and I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, and welcome to the July 2017 edition of the PRS Journal Club podcast. I'm Jordan Frey, PRS Resident Ambassador from NYU, and I'm here as always joined by my co-ambassadors Chad Purnell from Northwestern and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Noopur Gangopadhyay, craniofacial and microsurgeon from the Ann and Robert H. Lurie Children's Hospital of Chicago. Thank you very much, Dr. Gangopadhyay, for joining us for this PRS Journal Club podcast. The article we'll be discussing now is Tumor-to-Nipple Distance as a Predictor of Nipple Involvement, Expanding the Inclusion Criteria for Nipple-Sparing Mastectomy. And this is from Cornell in New York by Drs. Briar Dent, Jake Miller, Daniel Eden, Alexander Swistel, and Mia Talmor. And as a quick reminder to everybody listening, all of the articles that we'll discuss here can be read for free on prsjournal.com, and this includes an archive of all past Journal Club articles. So as a background, as we know, nipple-sparing mastectomy has become increasingly popular for prophylactic mastectomy as well as in appropriate oncologic cases and allows for complete preservation of the nipple areolar complex, which improves aesthetic outcomes. Traditionally cited criteria for being eligible for nipple-sparing mastectomy include an early-stage tumor that's smaller than 3 centimeters, a tumor-to-nipple distance of at least 2 centimeters, and clinically negative axillary lymph nodes, absence of skin involvement on exam, and a negative subareolar biopsy at the time of mastectomy. And obviously the major concern with preserving the nipple is occult nipple involvement, which is generally quoted anywhere from 5 to 25% in the literature and is not completely studied. While studies have shown increasing occult nipple involvement with decreasing tumor-to-nipple distance, the absolute distance recommended has varied from 0.5 to 2 centimeters in the literature. And others have argued against an absolute cutoff, rather judging candidacy based on clinical nipple involvement at the time of mastectomy. So the authors therefore sought to evaluate tumor-to-nipple distance in their patients who did and did not undergo nipple-sparing mastectomy using pathologic specimens to determine nipple involvement. And their institution did not set a specific tumor distance, but rather used clinical exam and preoperative imaging, evaluating for nipple involvement as a contraindication to nipple-sparing mastectomy. They performed a retrospective review of all patients undergoing nipple-sparing mastectomy with implant-based reconstruction for a therapeutic indication with preoperative MRI or sonogram. And they performed frozen and permanent retroareolar biopsies in all cases, and they divided nipple-sparing mastectomies into those with tumor-to-nipple distance greater or less than 2 centimeters, followed by greater or less than 1 centimeter. And they also compared rates of nipple excision, which represented nipple involvement, for both of these groups. Over the time period, there were 425 nipple-sparing mastectomies. 195 were included, as these represented those for therapeutic indication and that had preoperative imaging available. The nipple, areola, or complete nipple areola complex excision for positive pathology was performed in 22 cases, which represented about 11% overall. And of these 22 cases, frozen biopsies were positive in 13, and permanent was positive in 9 cases. And in each of these groups, both frozen and permanent results, DCIS was the most common pathology identified. Frozen sections for 9 of the permanent cases were either negative in 4 cases, and they were atypical or suspicious in 3, or not sent in 2 of the cases. Importantly, nipple involvement was not significantly different for cases with a tumor-to-nipple distance less than 2 or even less than 1 centimeter based on ultrasounds, MRI, or on both concordant ultrasound and MRI. And the average follow-up was about 1.5 years at 456 days. Notably, local recurrences developed in 9 cases for 4.6%, and 7 patients at 4.6% again developed metastatic disease. In their discussion, the authors conclude that a tumor-to-nipple distance as short as 1 centimeter should not be considered an absolute contraindication to nipple-sparing mastectomy, and therefore they recommend considering nipple-sparing mastectomy in any patient, regardless of their tumor-to-nipple distance, who would otherwise meet traditional criteria and who do not have evidence of direct nipple involvement on history, physical examination, or preoperative imaging, with nipple excision being performed for positive biopsy results. I thought overall this was an interesting study, and it was interesting they used imaging as well as the pathology specimens to kind of determine the tumor-to-nipple distance and compare the groups. And, at our institution, we've been doing a lot of nipple-sparing mastectomy, and it is interesting that there was really no hard and fast criteria for who is and who isn't a candidate. And as we've kind of been doing it more, 2006 was really when we started, to now, as the surgeons, both breast surgeons and plastic surgeons, have become more comfortable, we've really been expanding our indications. And we don't necessarily set a tumor-to-nipple distance. We've kind of been doing what the authors conclude, and just any clinical nipple involvement is a contraindication, obviously, and then we do frozen and permanent retroareolar biopsies, obviously excising for positive results. And we've looked at the cost effectiveness of doing those biopsies and found that it was cost effective, and also that the frozen biopsies, some people argue they're not accurate and therefore they don't perform them, but we found they were fairly sensitive. I think this was an interesting article that kind of adds to the literature and suggests that perhaps we should be doing this for more patients. So I'd be interested, Dr. Gangopadhyay, to hear what your thoughts were on the paper.
I agree with you, Jordan. I thought this article was very interesting, and if anything, it has raised several more questions for me in terms of how can we best either expand the indications for nipple-sparing mastectomy, and secondly, how can we help counsel our patients appropriately for who's going to be a good candidate for nipple-sparing mastectomy. The interesting thing about this article is that they really solely focused on, I felt, the oncologic criteria in terms of tumor size and tumor distance from the nipple areolar complex, and whether or not a nipple-sparing mastectomy would be an option. I think the other things that are very interesting and important for a plastic surgeon to consider, especially someone who specializes in breast reconstruction, at the end of the day are really the aesthetics. So just because we can do a nipple-sparing mastectomy, what is the result going to look like? And so the patient population that was studied, I think, is very different in terms of some of their pre-operative characteristics than some plastic surgeons may see at other areas in the country. And specifically, I'm referring to their low rate of smoking, the very low BMI, and then the very low sternal notch to nipple distance. And so this article made me very interested to see what the results are from an aesthetic standpoint and from a breast reconstruction complication standpoint for this patient population. So I'd actually be very interested to see a follow-up article addressing those issues for this patient cohort.
I think those are all really great points. And that is, especially, I think, as we've all kind of seen at a certain point, a breast reconstruction patient really becomes kind of an aesthetic patient, and they're looking for a really refined result. And all those factors you mentioned, radiation, smoking, especially large ptotic breasts, can be difficult to achieve a really excellent result with nipple-sparing mastectomy. It can take a lot of kind of technical work. You mentioned, again, the kind of oncologic aspects, and I'd be interested to hear your take on how involved do you think the plastic surgeon should be in the oncologic decisions that are made for these breast patients, and how do you feel that the preoperative consultation should be performed? For example, should there be a multidisciplinary team? Should the breast and plastic surgeons be seeing the patients in joint consult so there's kind of a unified message? What's your take on that?
I think that's a really important point. So as we go into this era of multidisciplinary team care, not just for our cleft and craniofacial patients, but for our breast reconstruction patients, for our head and neck cancer patients, for our sarcoma patients, I think having a consistent message between the oncologic breast surgeon and the plastic surgeon is really important. And certainly if we're trying to provide the best cancer care, theoretically within the same visit, they should be able to have access to the oncologist who may be making decisions about their chemotherapy, the radiation oncologist who may be counseling on them about the need for neoadjuvant or adjuvant radiation, and then certainly access to a psychologist and a social worker to help them navigate some of these decisions. As we've seen with the use of the breast Q, sometimes we don't get a good sense of what is really important to the patient. And so I think having them meet with multiple specialists in a team that can potentially get different pieces of that puzzle is really important. I hesitate to say that plastic surgeons should be intimately involved in making the oncologic decisions. I think the nice thing about being a plastic surgeon who does reconstruction is to not have to worry in some ways about some of those cancer decisions. Because I think when you become a surgeon that is treating the cancer, but then is also performing your own reconstruction, you potentially will make a compromise. And at the end of the day, the compromise should not be on undertreating a cancer to get a better aesthetic result, because I don't think that does the patient a good service. And I think it's a somewhat dangerous territory to get into. So I think the plastic surgeon should be able to comment on what is safe to do from a surgical standpoint, what they think potentially may give the patient a better aesthetic result. But I think if we run into the territory of commenting on minimizing the margin or taking less skin, if it potentially is going to put the cancer recurrence in a higher category or compromise other aspects of their oncologic treatment, I think we're in dangerous territory. At the end of the day, breast reconstruction patients start out as breast cancer patients. And we can't forget that our goal, of course, with cancer reconstruction is to give them back their sense of self, but we also don't want to delay their other treatments or compromise the cancer care.
I think those are really great points as well. It can be a fine line, and if you're the person doing the resection as well as the reconstruction and deciding how thick to leave the flap, you don't want to be leaving it too thick and then paying for it down the line. And I think it's one thing to work with the breast surgeons and kind of educate to try to make sure they're doing the mastectomy right at the superficial fascia and not making it too thin, but another thing completely to be the one doing that dissection yourself and having those conflicting goals. Chad, what were your thoughts about the paper?
I agree with everything that's been said so far. I think that nipple-sparing mastectomy is really becoming a very widely used technique, and patients are asking for this, and I think that our indications are expanding and our comfort with this procedure is expanding. So I think that articles about the oncologic safety of this are very important, and I think the authors really do highlight that these things that we see as quote unquote hard and fast guidelines about when is a nipple-sparing mastectomy safe, some of these guidelines aren't 100% perfect. And I think they've really done a good job of challenging that maybe we should be eliminating some of these rules that would potentially cause a contraindication to a nipple-sparing mastectomy. So overall, I really liked the article. What they did highlight, which I thought was interesting, is the thing that we're all afraid of, which is a patient that has a negative frozen section, but then they have a positive permanent section. And it was a small amount in this paper. There was only 4 patients, but nonetheless, it's a real thing. So Dr. Gangopadhyay, I wanted to ask you, in that rare patient where your frozen section was negative, so you left the nipple areola complex in place, and now your permanent section was positive, so you have to go and remove the NAC. What's your technical approach, especially if that patient's had a direct to implant or another situation where the defect's going to be difficult to close?
Yeah, so I think that's a very challenging patient population. So at the end of the day, I think it goes back to your preoperative discussion with the patient. And hopefully you and your breast surgeon are on the same page in counseling the patient that while it's a rare risk, it is a possibility that they may still lose the nipple if the pathology comes back. So I think that discussion needs to be had before the initial surgery. So the way I handle these issues, if the frozen was negative intraoperatively, but the final pathology a few weeks later comes back as positive, is that, again, you see them with your breast surgeon, and they have to be aware that when you go back to the OR, the entire nipple areolar complex is going to have to be removed. And I think your reconstruction at that point really depends on 2 things. One, it depends on if you've left any additional skin to close. And certainly with a direct to implant, I often counsel my patients that they will likely be smaller in size than they were preoperatively. And I try not to put in an oversized implant up front because it's pretty challenging. And so if you have some of that skin laxity, then potentially you're going to be able to close your nipple areolar complex primarily. I think that's a very uncommon situation to be able to do that. I think what's more likely is that you're going to be left with a circular defect over a taut implant. I prefer to put my implants in a complete submuscular plane. And so in that situation, you are able to take potentially a full thickness skin graft from either the inner thigh or the groin, and you can actually resurface right on top of the muscle that full thickness skin graft. And then after they've healed, you can offer them one of two things. You can offer them a 3D tattoo, essentially on that patch for your nipple reconstruction, or when the soft tissues have relaxed, you can try to excise that and recruit some of the mastectomy skin for a more traditional sort of C to V or star flap. I think the other thing to counsel them is there's a chance that in the situation, they may either have to downsize the implant during that operation, or they may have to go to a tissue expander because you're not going to have enough soft tissue to completely cover it. And certainly if you are in the habit of using a biologic material such as an acellular dermal matrix to help support the inferior pole of your implant, which is often the case with larger direct-to-implants, then in those situations, you have to counsel them that a graft is not going to take on a graft, and they may even need to lose the implant entirely and come back for delayed reconstruction.
Those are really good points, and obviously none of us really want to be in that situation, but if you do enough breast reconstruction, it's a situation you're going to end up in at some point. Shuja, what did you think of the article?
So I agree with everything everybody said so far. I thought it was a really good study. I thought it was very interesting. I thought there was a good review of the literature, especially from the oncologic breast surgery standpoint, and it was a good review of the indications and contraindications of nipple-sparing mastectomy. Again, I agree with Dr. Gangopadhyay that their population had a relatively low BMI, non-pendulous breasts, low comorbidities. They also, in their discussion in the introduction, talk a lot about the use of MRI to detect nipple involvement, but they did include a number of patients who only had an ultrasound, and that really wasn't discussed in terms of sensitivity and specificity to detect nipple involvement when they were using that in their criteria. So that would be one thing I'd be interested to hear more about. And as with pretty much all of our studies, the need for prospective, large population, multi-center studies can't be understated for this issue. But, overall, they had their overall number of patients who had pathological nipple areolar involvement were low, possibly contributing to their insignificant difference. But overall, I thought it was a great study. One thing I wanted to ask is that we had discussed in our April journal club about preoperative MRI for consideration for oncoplastic reduction/reconstruction, where if the excision of the tumor was going to be over 30% of the breast, that the oncoplastic reconstruction was not going to be a good option. They talk about MRI in this article, and again, they talk pretty extensively about using that to look for nipple involvement. A lot of times these patients are ending up with MRIs anyway from the breast surgeon, especially for breast conservation therapy. But Dr. Gangopadhyay, are you routinely getting MRIs on your breast reconstruction patients for either of these indications? And if so, are you really spearheading that initiative, or are the breast surgeons that you work with going ahead with that?
I would actually say the decision to get an MRI, at least at my previous institution, was more driven by the breast radiologist and the breast surgeon. Certainly, if the information is there, I will utilize it when planning my oncoplastic reductions or when planning an approach with the breast surgeon to do like a nipple-sparing mastectomy or a skin-sparing mastectomy. I don't think use of MRI is routine at every institution for kind of early stage tumors. Certainly where I trained and where I have worked, usually MRIs were reserved for people that were higher risk, potentially patients that had a familial breast cancer gene or hereditary breast and ovarian cancer syndrome, and any question of calcifications that may be related to a prior surgery, whether that was for breast reduction or patients that have had a previous lumpectomy and oncoplastic rearrangement or reduction. And so I think using the MRI when it's there is certainly very cost effective. However, I think purely to order the MRI to help with your reconstruction is probably not the best use of our resources. So I think if the information is already there, I think that should really be driven by the breast surgeon and the breast radiologist, and then the plastic surgeon should use that information. But I probably would not routinely recommend ordering it, especially if it's not going to significantly change your management, which I don't think it does.
Great, thank you.
You're welcome.
I agree completely, and that kind of agrees with what we've been doing here. And the MRI is great if you have it, but it's really kind of the clinical exam and then what you're seeing it with your biopsies and the time of mastectomy. I think this has really been a great and educational discussion that I think will draw to a conclusion here. But everyone, remember to tune in to the other 2 articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcast every month. And also don't forget to participate in our monthly Twitter #PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. And lastly, and most importantly, thank you again, Dr. Gangopadhyay, for joining us.
Thank you, Jordan, for leading a great discussion.